So once again, good morning today, and we are continuing the last topic, that is the swelling clinical examination. So far we have finished the inspection. So let's again recapitulate what are all the points we have discussed in inspection. So inspection, basically it is the site, number, shape, size, surface, skin over the swelling, then pulsatility and other tests. So far we have finished this, and now let us go to the palpation. Okay. So in palpation, first let us concentrate on the first here we have to again first confirm the number of swellings. That is very, very important. So number. So number is important here, and of course patient might not have told you the number. So you have to, in the history itself, you might have asked him about the other similar swellings. Once he gives that there are other swellings, then in inspection, of course, you will confirm, but on palpation, you have to doubly confirm them first, then which swelling to be presented mainly. That is important. So here, 2 points you have to remember. One is the swelling which the patient has given history about. That is first thing. Then second thing is, on your examination, any swelling which is bigger or the biggest swelling, you have to present about it. Regarding other swellings, what you have to do is, you have to say that the other swellings are having similar features with varying sizes. That's all. So first, in palpation also, number is very, very important, by which already we have, in the last class, I have shown you different types of multiple swellings, of which for today's class it is important that first is the lymph nodal swellings. Okay. Now let us again go back. So next is temperature. So how to examine temperature? Here in the video, he has shown a wrong technique. That is very important. Whenever you have to feel the temperature, first you have to examine in the normal part, because individual temperature varies. So first you have to examine the normal side, then go to the abnormal side. So first here, then normal side. Okay. So these are the cases where there will be increased local temperature. That is So here you can see that inflammatory swellings are having local rise of temperature. Similarly, any soft tissue sarcomas, particularly the fibrosarcomas and other sarcomas, which are rapidly progressing, they will have more temperature. Similarly, vascular swellings also, like hemangiomas or AV fistulas, they will also be having local rise of temperature. So, this is the first thing you have to see, that is local rise of temperature. Then you have to go for the next one, that is the tenderness. So here, why you have to see local rise of temperature and tenderness first? That is, if any swelling is, there is a local rise of temperature and tenderness, you are not supposed to examine in an usual manner. You should take more care to examine these cases. Okay? And usually in the examination, except that it is mild local rise and there may be tenderness, we will not give severe acute cases, right? Now, let us see again. So, tenderness. When will there be tenderness? What is tenderness? It is pain on exertion, on examination. Here, one thing I want to tell you is, you should not ask the patient whether it is painful or not. See in this video, the patient is wincing with pain. See, is wincing with pain. That is important. You should not ask by going on pressing, is there tenderness, is there pain, is there pain? You should not ask. You should observe the patient. Then only you should tell whether there is tenderness or not, right? Once these two are over, let us go to the next one. So the normal size, the shape, all these things you have to examine. So here you are justified in using the tape. So only in palpation we are supposed to use the tape, right? Here in 3 dimension, both length, breadth and the other, the width also you can measure. Now let us go to the next part of examination, that is the surface. So surface. Surface, already I have told you in my earlier class, surface will be smooth or lobular like this. 2 lobules are there. Or it can be nodular. Here he has given example of nodular swelling, thyroid. Can you tell me the other nodular swellings, examples? Already he has shown thyroid, but are there any swellings? Yes. Lymph nodes, neurofibromatosis is nodular, not nodular, no. All of you are writing neurofibromatosis or neurofibroma. It is wrong. Neurofibroma is multiple. Surface will be smooth only. So, in nodular surface, swelling is single, but it can be having nodular surface. So, somebody has written breast. Breast can have usually not nodular surface. Lipoma is, just now I have demonstrated, it is lobular surface. Nodular surface, you have to think of only lymph nodes. Okay. Now let us go back again to the presentation. So apart from thyroid, nodular surface is lymph nodes also. Right. Next. So naturally, malignancies will have irregular surface. Next here, he has given H. For a swelling, please don't use H. It is, what is the one that we have to say for a swelling? What is the counterpart of H? Okay. So, margin. Margin is also described for an ulcer, just like edge. Yes, border. So border is the one which we have to use for a swelling. So border is the one which we have to use for a swelling. Okay. So please don't use H. Now let us go. So how can be borders? The borders can be well defined and regular. They can be well defined and irregular. First of all, you have to say whether it is well defined or diffuse. That is most important. Then, is it regular or irregular? Then the third dimension is it round or sharp? So, round or sharp. So, borders can be either round or sharp. Of course, these round or sharp borders are mainly for abdominal organs, any enlargement. Usually, most of the surface swellings are round, usually, right? So, let us go back to the presentation. So, well-defined, round, regular. Well-defined, irregular. Then finally diffuse and ill-defined. So here you will see the demonstration of surface and borders. So here it is irregular border. See, irregular border. This is smooth surface, and the borders are see, the borders are ill-defined here. You are unable to know the borders. Now, in the borders itself, there is another done that is called as so-called slip sign. So this is called as slip sign. So you can see that there is what I have written, slip sign. That is, where do we find this slip sign? In which cases? Yes. So all of you have written lipoma, very good, correct. So slip sign is very characteristic of lipoma, right? So how to demonstrate the slip sign also, it is clearly shown here. You can see that, see how it is slipping under the fingers. Next is consistency. Let me again stop here. Though he has shown the types of consistency, we don't usually say like that. So there are basically only 3 consistencies. So consistency. Soft, firm, hard. Soft again can be so solid swellings can be soft, cystic swellings can also be soft. Similarly, hardness. Hard, how do we classify hard? Can anybody tell me? Hard, how do we classify? Yeah, bony and another one? Stony and bony, correct. So stony hard and bony hard. So which is hardest? Which is hardest? Bony hard or stony hard? Which is hardest? Stony, wrong. It is other way. So bony hard is hard. So either stony or bony hard. So this is how we will say consistency: soft, firm, hard. And you should, cystic is not a consistency. When any cystic swelling, you should say it is soft and cystic. You should not say it is cystic in consistency. It is soft in consistency and it is cystic. That's how you have to tell, right? So now let us go back to presentation. So soft, firm, hard, right? Now, what is this Paget's test? You are shown now. Paget's test. What is this Paget's test? Can anybody tell me what is Paget's test? Yeah. Fluctuation, there is fluctuation test also we do. Somebody has written fluctuation. It is not equal to Paget's test. Paget's test is sort of fluctuation, but we don't say fluctuation. So Paget's test is whenever the swelling is small, when you are trying to elicit the consistency, and if it is soft, fluctuation, it will swelling. No, you just listen to me. So whenever a swelling is small and you want to assess its consistency, and if it is soft, you want to know whether it is cystic or not. In those cases, if you try to palpate, the swelling will move away. It will be a mobile swelling, so it will move freely and you will not be able to elicit the consistency. So in those cases, this Paget's test is useful. What we do is, we will pick up the swelling as is demonstrated in this. So I'll show you when this comes. Okay. So that is eliciting the consistency, and this is Paget's test. See, in a small swelling, you have to fix the swelling first with the left hand, and then feel at the center and periphery. At the center, a soft swelling will be what? Soft swelling will be at the center. Will it be soft or firm? Small swelling by Paget's test, we are feeling at the center of the swelling. After fixing it with one hand, you will fixing with one hand, and then you will be feeling at the center. How will it be at the center? Will it be soft or firm? For a soft swelling, yes, good, soft. A soft swelling will be soft at the center, and relatively, please bear in mind, it will be firm at the periphery. That is important. That is the basis of Paget's test. So similarly, a cystic swelling will be cystic at the center, whereas at the periphery it will be soft. So that's how he is trying to demonstrate both at the center and at the periphery also, right? Center and periphery. That's how you have to see for the consistency. Now, once a swelling is soft, then you have to elicit sign of indentation or molding. In which cases it is positive, sign of molding or indentation is positive. Soft hernia. Why there should be sign of indentation? Hernia is reducible, not indentable. No. What are the examples of indentable swellings, in other words? My question, please listen. Somebody has written. Yeah, sebaceous cyst, very good. Any other swelling? Yeah. Once you see the demonstration, you will be able to know better. So, how to do sign of indentation, you please see. So, this is a sebaceous cyst. You see, after pressing, the change of shape of the swelling is remaining. It is not again regained. See, it is not regained. So that is the sign of indentation. It is present in sebaceous cyst, dermoid cyst, and somebody has answered a hernia with content something like that. If there is a colon loaded with fecal matter, then it can be indentable. So these are the three situations. One is sebaceous cyst, another is dermoid cyst. Finally, colon need not be mass. Colon, fecal loaded colon is also, that is physiological or normal. That also is indentable, right? So once again, please see the sign of indentation. So here it is not regaining its shape. If you apply pressure, it is going to stay like that only. That is very, very important. Whereas sign of compression, it will regain its shape. So this is what he is demonstrating is the variable consistency. See, particularly malignant swellings can vary from hard to soft, hard, firm or soft. So variable consistency is the characteristic feature of malignant swellings, and it is because of degeneration that is taking place within the tumor. So variable consistency, whenever there is variable consistency, you have to think of malignancy, right? Now, once the swelling is soft, you have to do, apart from the fluctuation, other tests. So these are the tests which you have to do. Whenever the swelling is soft, you have to demonstrate fluctuation. This is very, very important. Before doing fluctuation, what you have to do is you have to fix the swelling. That is very, very important. That's what is demonstrating. You please see carefully the video. So now see the fluctuation. So what is fluctuation? Transmission of an impulse in two directions. You are supposed to see in two directions. That is very, very important, at right angles to each. Can you tell me, if it is fluctuant in one direction, what do we call that fluctuation? What do you call fluctuation that is present in one direction? True fluctuation should be present in both directions, both vertically and horizontally can be there. But sometimes even normal tissues can be fluctuant in one direction. Example also I'll tell you, but first tell me, what is that fluctuation that is called? Already I have given a tip also. What is actual fluctuation is called, I told you. So you can tell me. Fluctuation in one direction, what fluctuation we call? Fluid thrill is different. No. Any other answer? It is called fluctuation only. I told you now. It is fluctuation only. Very good. Pseudo fluctuation. That is important. Yes. So, now you tell me, which normal tissue will have pseudo fluctuation? Normal tissue in the body. You can even else it on yourself also. This pseudo fluctuation. Subcutaneous tissue, no? Yeah. Somebody has written lipoma. Lipoma is not normal, isn't it? Very good. Muscles. Muscles. So, muscle is fluctuant in a perpendicular direction to its line of fibers. So for biceps, it is fluctuant horizontally, whereas vertically it is not fluctuant. So that's what he is demonstrating. Please carefully see how fluctuation can be elicited. Basically, you need to fix the swelling. Then only you can elicit. See, in two directions, both vertical and horizontal, you have to elicit. That's how fluctuation you have to elicit. So this depends on the Pascal's law. So fluid, the pressure is transmitted in all directions equally. That's why it is fluctuant. A fluid filled swelling will be fluctuant in, see, muscle is horizontally, see, vertically it is not fluctuant. Horizontally it is fluctuant. That is called as pseudo fluctuation, right? So for smaller swellings, again, just like Page's test, what you can do is you fix the swelling like this and then press in the center. The pressure wave will be transmitted to the both the thumb and the index finger of your left hand. So that is also part of Page's test. One is, first is the pressing over the center of the swelling for a small swelling. Another method is pressing in the center and appreciating the fluid wave in the other hand. That is also called as Page's test. Okay. For a small swelling, you have to fix it. Otherwise, it will be mobile. See how it is fixed, and then fluctuation can be elicited. With this, it is clearly demonstrating that the fingers are separated. That is, for small swellings, you can do it. Whereas large swellings, you can do with the fingers. Right. So already I told you about pseudo fluctuation. What is this cross fluctuation? Can anybody tell me what is cross fluctuation? Cross fluctuation. What is it? Of course, it's not that easy. You might not have heard about it, but you can guess, can be correct sometimes. So cross fluctuation, fluctuation not at right angles, no. That is not correct. So I'll give you a tip. Bursa, no. So suppose the swelling is there in two different sites. Part of, so synovial fluid, you can not exactly correct, but as I told you, yeah, somebody has given between two cystic swellings. That's correct. So if the two cystic swellings are communicating, then only cross fluctuation will be there. Otherwise, it will not be there. So your answer should be fluctuation elicited between two communicating cystic swellings. That's how it is demonstrated. Now, what are the sites where you can elicit cross fluctuation. So he will demonstrate it. Just see. So felt in large soft swellings. So that is pseudo unnecessary. That is don't bother about it. So another example of pseudo fluctuation is a lipoma. Now, so two separate cystic swellings communicating with each other. That is very, very important. So what are the three cases? One is compound palmar ganglion. So as the name itself explains, it is a compound palmar region ganglion, usually tuberculosis. There will be compound palmar ganglion. Similarly, psoas abscess, which has come out into the thigh and presenting as a swelling in the thigh. As you know, psoas muscle will be in the posterior abdominal wall. So around it, the psoas muscle, there will be abscess, sometimes because of liquefaction of the lymph nodes, particularly again in tuberculosis. So it can come out and then it can also present in the thigh. Then the other diagnosis is deep plunging ranula. So both, it will be presenting both inside oral cavity and outside in the submental or submandibular region, right? So these are the three possibilities of cross fluctuation, okay? Right, next. So how to elicit cross fluctuation? See, one finger is here, another finger is here. Both can be fluctuate. So once the swelling is soft and it is fluctuant, that means it is cystic, then you want to know the nature of cyst means fluid filled sac only. So next you want to know the nature of that fluid. That's why you do this test called as transillumination. So what is this transillumination? So you will put a pen torch and then particularly the requirement is you should be in a dark room, or at least you should make the room a bit dark. Then only you are supposed to do this transillumination. For this, you are supposed to have a pen torch and a transilluminoscope. These are the two things that are required for doing this transillumination. So just see, observe, then we will further proceed. So demonstration of transmission of light through a swelling. See how brilliantly it is translucent. For some swellings you don't need, like this, a hydrocele, you don't need a transilluminoscope. But some swellings where it is thick, the skin is thick or the sac is thick, then you need to use transilluminoscope. So this is how transilluminoscope. Here, of course, can anybody tell me, is it the correct method or a bit wrong? Not exactly wrong, but there is some mistake they have committed in this. Can anybody tell me what is that mistake? So you might have done so far transillumination in many cases. Yeah, dark room, okay. That is one thing. Another, illuminoscope position, very good, correct. So they should be always in 180 degrees. So suppose this is the swelling. Torch should be here. Luminoscope should be here. Not like this or not like this. It should be 180 degrees. So that is the exact position. Otherwise, because light will not travel in angles. Light will travel like this only. It will not travel like this. So that point you have to observe. Of course, it is not a big mistake, but some cases, I used to say most common cause of negative transillumination in a hydrocele is mistaken technique or a faulty technique. So that you have to take care. Yeah, you can see how it is performed. See, it is red. So you should do it multiple times. Then only you will be clear. Just once you will see and then you cannot appreciate. Now, before that, I just wanted to ask you, what are the diseases or cysts which are brilliantly translucent? Yes? You can tell me one or two. Meningocele, good. Next. Granula, good. Next. Epidermal cyst. Epidermal cyst is never translucent. No. Epidencephalus, same thing like meningocele. No. Any other diagnosis? Cystic hygroma, good. Next. Lymph cyst, very good. Any other? Hydrocele need not be brilliantly translucent always, but something around testis. There is another cyst which is very brilliantly translucent. Around testis, what is there? Epididymal, yeah. Epididymal cyst is brilliantly translucent. So now you see, that's what is written here. So these are the things: cystic hygroma, epididymal cyst, meningocele, granula, and congenital hydrocele. So they are brilliantly translucent. Now you see next test, let us see. So impulse on coughing, already we have seen an inspection. Here on palpation also, you have to confirm impulse on coughing. Can you tell me what is the difference of mentioning impulse on coughing on inspection and palpation? Is there any difference, or you will say both the impulse on coughing is present both in inspection and palpation? Is there any difference of mentioning impulse on coughing on palpation? Because on palpation you are actually feeling. No, we are in not in reducibility, we are in impulse on coughing. Contents you can mention for hernia, but impulse on coughing, consistency will vary depending on the contents, but not impulse. Hernia impulse on coughing is called as on palpation. So on palpation, we call it as expansile. Expansile impulse on coughing. This you should tell only on palpation, not on inspection. Okay. So, yeah. So now let us go back to the video. So this is how expansile impulse is elicited. See how it is expanding. Okay, each cough bout is expanding. Of course, in children, you know that on crying, you can elicit expansile impulse on crying. Now, let us go to reducibility. So, hernia, whenever there is impulse on coughing, it will be reducible. For abdomen, it is the hernia. For the chest, it may be empyema, and see how it can be reduced nicely. So if it is not completely reducible, then you have to use a method called as taxis. Somebody has mentioned already about taxis for cough impulse. Reducibility is again present for a meningocele or myelocele. So these are the reducible swellings: hernia, meningocele, varicocele, and saphenous varix. Of course, these two are not very common, but hernias very common, and meningocele you may see one before you leave the college. Okay. So let us see how it can be reduced. And again, I want to tell you here again. So two features of a soft swelling will be there. Already I told you about indentation and reducibility. In indentation, it will not return to normal position or shape again. Whereas similarly in reducibility also, unless you exert pressure, a reducible swelling will not come out again. If you have reduced completely, it will stay put like that, stay reduced, it will not come out. So these are the two features of a swelling, of a soft swelling. One is indentation and reducibility. Whereas the other feature that already we will discuss next is the compressibility. Compressibility, after reduction or compressing, the swelling will again bounce back to its. So this is compressibility. You can see that once it is pressed, it will again bounce back to its normal shape. That is compressibility. Okay. So compressible swellings are vascular. Naturally, they will be compressible. Pulsations, of course, you have seen already. Pulsatile swelling, aneurysms or AV fistulas can be pulsatile. See, aneurysm of aorta also. There is difference in these pulsations. So the pulsations may be either transmitted or expansile. So transmitted only perpendicular. To differentiate between a transmitted pulsation and expansile pulsations, what is the test? Please tell me, what is the test where we can differentiate a transmitted pulsations which are perpendicular, exactly like this. not like this, expansile pulsations. Yes, Nicolan, that is, Branham's test is not used here. No, Branham's test is different. But at least tell me the position. Two finger, yeah, two finger you can tell, but if you want to be absolutely sure, particularly abdominal aorta and the aorta transmitted pulsations of aorta in the abdominal lump, what is the position you have to ask the patient to adopt? You will turn the patient from supine to what position? Supine you cannot, no. Lateral, no. So it is, we will know once you see the video. So that's the transmitted pulsations. Now you see the patient. What is this position? Yes. What is that position? Knee, elbow. Very good. So knee, elbow position. Okay. Right. So that is knee, elbow position. And you can, next is thrill, of course. Thrill for particularly in the neck region, we can feel of either carotid if it is diseased, carotid artery stenosis, or a goiter which is very highly vascular. Once there is thrill, you can put your stent, and then here for also the, yes, next is very, very important, that is the fixity to the surrounding structures. So once a swelling is immobile, what is your inference? Swelling you are seeing, it is immobile. So what is the inference? Fixed to underlying which structure is swellings, suppose it is fixed to deep. How deep? Deep bone. So it is fixed to underlying muscle is wrong. Somebody has typed fixed to underlying muscle. No. Fixed to underlying bone. Then only it is immobile. So once a swelling is immobile, so after finishing all these tests, you have to do mobility. Once it is immobile, you will say it is either arising or fixed to the underlying bone. Example is an osteosarcoma that is arising from the bone, or a fibrosarcoma that is fixed to the bone. Both are immobile. So that is the first thing you have to say. So once it is immobile, your plane of swelling is already known. Whereas if it is mobile only, you have to do all these tests. So what are those tests? So skin pinchability. Next is skin pinchability. So how do we pinch the skin? You will see here. See, here it is not pinchable, isn't it? So this is a keloid which is arising from the skin. So skin will not be pinchable here. So see, it is not pinchable. Whereas if it is subcutaneous like this, skin is typically pinchable. Once skin is pinchable, it can be either subcutaneous, it can be intramuscular, it can be bony. Three possibilities. Whenever a swelling is, for a swelling, there is skin pinchability. It cannot be from the skin, but it can be from both subcutaneous tissue, from the muscle, or from the bone. But sometimes the subcutaneous swellings can be fixed to skin. That means, particularly in malignancy, the skin involvement will be there. As you can see, in this case, carcinoma of the breast, skin is not pinchable because it has infiltrated into the skin. That means it is T4B. Sometimes skin is pinchable, but there is puckering. This is called as tethering of the skin. This we will not put it in T4. Tethering is different, fixity is different. Both are different. If a swelling is fixed, it is T4B. Whereas if it is, see, here he has given clearly. So if it is mobile, and then if you contract underlying muscle, if it is becoming prominent and remains mobile, it is subcutaneous. Whereas if it becomes fixed and immobile, it is intramuscular. If it becomes less prominent and difficult to palpate, means it is submuscular. It can be both from the bone, or if it is mobile like this, it is arising from the, see, from the muscle, pectoralis major, and then if the muscle is contracted, you will see how it will become fixed. See this carefully. Now you see, see, the movement has become restricted. That's because it is fixed to the underlying muscle, right? Next, of course, as I told you, a bony swelling fixed to bone. What is the diagnosis in this case? Can you predict? It is in the jaw. Can you predict? Jaw swelling. What is the common jaw swelling? Around the middle age. Jaw swelling is underlying pleomorphic adenoma. Carefully see this. Again, I will show you. Carefully see this. It is a jaw swelling here. Carotid is here. Not this is here. So what is that? Jaw swelling. So can you predict what is it? So in dental surgery, we will ask them to tell you about what is called as adamantinoma. So adamantinoma. Adamantinoma will be fixed to the bone because it is arising from the mandible, right? So that's how we can. So what are again the points in palpation? Temperature, tenderness, the size, shape, the surface, not edge, it is border, the consistency. Then if it is soft and fluctuant, then you will go for other tests like transillumination. If it is soft, you will also do the tests like reducibility, compressibility, and other things. Then finally, you have to see the plane of the swelling. The plane of the swelling can be cutaneous, subcutaneous, intramuscular, or fixed to the bone or bone. So these are the different planes. After doing palpation, you will go for uh, So you have to go for regional examination. In regional examination, you have to see for these three things, that is lymph nodes, are there any pressure effects, what about the joint. So these are the things which you have to look for. Once you examine regional lymph nodes, particularly in malignancies, like see in melanoma, you will examine inguinal lymph nodes like that. And then, of course, you have to go for the bone erosion, particularly in dermoids, tumors, and of course, weak distal pulse if the swelling is blocking the artery. If it is blocking the vein, there may be edema and dilated veins. Nervous compression will lead to paresis and wasting of the muscles. Then finally, you will go for systemic examination. So that is general examination. Okay. So that finishes your examination of a swelling. In the next week, Professor S.V. Kumar will demonstrate examination of an ulcer. So that's how we can examine a swelling or an ulcer. Now for tomorrow, as already I told you, you will have a test on esophagus. Multiple choice questions will be about 25 in 20 minutes. You have to do it. Of course, this is not basically to test you. That's why the questions are almost self-explanatory. Don't think that paper is so easy. Why it is like that? This is mainly will work out as a refreshment for you of your knowledge about esophagus, right? Okay, thank you. Page.